All right, good evening, everyone. Thank you for joining the webinar. If you're out there on Facebook Live, I'm so excited to be presenting our webinar tonight on sleep shouldn't be a pain. And pain is such a factor in interrupting so many people's sleep. And so our guests tonight are all the way from Bellevue, Washington. So I want to welcome Dr. Zachary Fisk and Dr. Christina Julian. And they are part of Acute and Chronic Pain Therapies, like I said, located in Bellevue, Washington. It's a one-of-a-kind practice offering cutting-edge in-office protocols, including post-operative pain management, nerve pain treatment, pain treatments, ketamine infusion, which I'm really interested in hearing about, regenerative medicine, including PRP, A2M, IRAP, stem cells, medication management, and so much more. So if you guys don't mind, I'm going to share my screen and we'll just make this as interactive as possible. If you're out there on Facebook, feel free to chat your questions on the comments. And for those of you in the webinar, please use the chat or the Q&A to let us know what your questions are. So I'll share my screen and let you guys take it away. All right, can you see that?
Yes, we can.
Right, I'm going to put it in a slideshow if I can. How do I do that? Sorry, this Zoom bar is blocking my. Nope, that didn't work. I apologize. Just a second.
That's all right.
Did that work? No? Can you see it?
No, actually, I don't see it anymore.
Oh, it went away. All right, here we go. Better?
Yes.
Okay.
Oh, there you go.
We have one screen at a time.
It clicked stop sharing and this at the same time. So depression, chronic pain, and sleep. So the impact and solutions. Welcome, both Dr. Julian and Dr. Fisk. I'll be right here and we can just interact as we go. And I will do my best to advance your slides. So tell us more about yourselves.
Julian, do you want to start?
No, I think you're first.
All right, there we go. I'm Zach Fisk. I'm a anesthesiologist and pain medicine specialist in the Seattle area. Been running our current practice, which is called Acute Pain Therapies, Acute and Chronic Pain Therapies, for the past, I guess it's been 5 years now. Before that, I worked at hospitals delivering anesthesia and managing acute postoperative pain, which is the practice of putting in nerve blocks and optimizing medications after surgeries. And I thought that one of the major weaknesses that people have after they get out of the hospital is they have nowhere to turn for severe pain right after surgery. And so I thought a unique practice could be to set up a place where they could turn within those couple of weeks of sort of the dead zone between they just got out of the hospital and the 2-week follow-up with the surgeon. I thought that that might be a good way to bridge that gap and minimize their risk of having severe pain or becoming addicted to opioids, which can occur very quickly. And when I opened that practice, one of the major tools I used was ketamine. And it turns out ketamine is extremely effective for not only pain, but also psychiatric and psychological difficulties that people have, such as depression, PTSD, anxiety. And so ketamine became a major part of this outpatient practice. And over time, I was able to develop other protocols to help with perioperative pain. For example, patients who want to consider alternatives to surgery, such as regenerative injections, and patients who have chronic pain as a result of surgery or just generally, helping treat those patients who have severe nerve pain, joint pain, tendon pain, chronic back and neck pain. 2 years after I opened the practice, Dr. Julian, who's with us, who is board certified in interventional pain management, joined the practice. And now we have a pretty comprehensive protocol for treating a lot of different kinds of pain. People often refer patients to us when they don't know what else to do. And we have a decent success rate even in those situations. So since we're both board certified anesthesiologists, I feel like we have a unique setup too, because we can provide sedation for a lot of those procedures. And we can both cover ketamine in a very a safe and professional manner, given our background in anesthesia. Dr. Julian, would you like to introduce yourself as well?
Yeah, sure. So I'm Dr. Christina Julian. I'm originally from the East Coast and decided to move out here to the West Coast after I finished my residency and my fellowship. I went to college in Chicago, and then I did my medical school and my anesthesia residency at West Virginia University, and then I did my chronic pain fellowship at the University of Maryland. So I have more of kind of a traditionalist chronic interventional pain background. Most of my injections are with the X-ray machine or the fluoroscope. I do some injections with ultrasound guidance. I focus a lot on spine, cervical, thoracic, and lumbar spine injections. I do joint injections. We really do the full array of chronic interventional pain procedures, not only steroid injections, but also radiofrequency ablations, and any procedure that we can do to really help with chronic pain. So I think that kind of the combination between Dr. Fisk and myself, he treats a lot of the acute pain, acute post-operative pain, and then I do a lot of the more chronic pain. In addition to our ketamine infusion. So we really provide a comprehensive pain management center here in Bellevue.
Well, this has been a big part of my life, you guys. I had rheumatoid arthritis as a child. I had lymphoma, I've had breast cancer, gone through all the surgeries for, double mastectomy. And I've had like 2 major bouts of chemotherapy in my life. And then I ended up having 2 disc replacements. So I really, really understand what it's like to be in pain, and you almost don't even know how bad it is until you get better, you find a treatment. So I want to say thank you so much for being here, and tell us a little bit about, like, when we're in pain, it leads to depression as well, and this all impacts our sleep. So can you share with us sort of your knowledge and background, and how you obviously you shared your background, but your knowledge and helping someone realize, okay, I need help, and it's okay to ask for help?
Sure. As an anesthesiologist, I never dealt with depression very much, in that setting. But when I started treating depressed patients who were refractory to all other treatments, you naturally develop an expertise over years of doing that. And right now we do thousands of infusions for depression every year. So I get to see a lot of different patterns of depression. And some people don't even realize they're depressed. Some people manifest their depression primarily as potentially a sleep disturbance, low energy, low motivation, difficulty sleeping. That combination is actually quite typical. It's one of the first questions I usually ask people when they're coming to me for evaluation of use of ketamine for, psychiatric or psychological problems. We get actually most of our patients by referral from psychiatrists. And so obviously these patients haven't responded well to other psychiatric treatments, but oftentimes they do. We actually studied our own patient population. We found that about 68% of our treatment refractory depression patients respond to the treatment with ketamine. And we measure that based on their continuance of the use of ketamine. Because, it's one thing to say their scores temporarily went down, but it's another thing to say that they decided that it was so worthwhile that they continued the treatment protocol. And that some people might say, "Oh, ketamine's isn't," like, I had a Russian guy was like, "Is this not party drug? Why would I take this?" And it turns out that it's actually not the most fun experience for many people, and it can be difficult to get through these infusions in some cases. Although we have protocols to minimize that, but ketamine turns out to be a treatment that you probably wouldn't want to continue unless it's working extremely well. one of the ways that it can help a lot is with sleep disturbance. And I find that we have a PHQ-9 sort of survey that we have patients fill out every time. And if they respond well in that sleep category, it usually means that it's helping quite a bit. And the majority of patients with depression I see have sleep disturbance, the vast majority, I would say.
And then it just affects the way they sleep, and like a hamster running on the wheel, right?
Yeah, the classic pattern is difficulty falling asleep and then difficulty staying asleep, especially the latter, usually early morning awakenings, difficulty staying asleep. And sometimes, sleep latency can be an issue. One thing I feel like we're still lacking is management of sleep hygiene, really, because I'm terrible with that. Actually, I break all the rules myself, and so it feels hypocritical to preach what you don't practice. But
it's a hard thing to be disciplined at if you're an overachiever, and I certainly am one of those. But it's so important to go to bed at the same time and wake up at the same time. And
no, I break all the rules. No exercising near bed. Nope. I don't follow that one. Don't eat near bed. Nope. Don't watch TV near bed. Nope.
Yeah. You want to be in bed and drink your coffee and get on the computer.
Coffee, yeah, that's what I did right before this podcast. So far I'm 0 for 5.
So tell us a little bit about how chronic pain impacts sleep, because this was a huge thing for me. I mean, when you're in pain, your brain doesn't know what to do, but just feel the pain. At least
exactly. Yeah. There are several ways. So, I mean, when you're in pain, obviously you can't get in a comfortable position, right? It's hard to find a position where you're comfortable for a prolonged period of time. It typically also wakes people up from sleep, depending on the type of pain. If it's arthritic pain in the shoulder and you roll over and you lay on that shoulder, that can kind of arouse you from sleep. So people with chronic pain are very frequently changing positions, which causes a little bit of you're more aroused, you're more awake. So then you're not getting your really good REM sleep. You're not getting your good deep sleep. So pain itself leads to not only non-restful sleep, but fragmented sleep as well. There's also a lot of anxiety around, knowing night's coming and you need to go to sleep. And there's nothing worse than laying there staring at the alarm clock, at 3 a.m. thinking, if I fall asleep now, I would get 3 hours, and then an hour later, if I fall asleep now, I would get 2 hours. I've done that myself.
Don't look at the clock. Don't look at the clock.
You can't look at the clock, right? Because there's a lot of anxiety around it.
Yeah.
But then kind of on the flip side, ineffective and insufficient sleep can also really significantly alter your pain perception, because your body's not having that time to rest, to rebuild, to rid itself of toxins, all of those restorative things that sleep provides. So you're not getting that, right? And just the lack of sleep kind of emotionally puts us on edge. So then we're less able to cope with the chronic pain issues that we have. So even a small pain is perceived as something much bigger, right? Or it's more impactful emotionally, because you're not getting restful sleep. So it's definitely a two-way street. The chronic pain impacts the quality and the duration of the sleep, but then fragmented, insufficient sleep affects your pain perception and worsens it. So it's really a kind of a vicious cycle.
And we all know the opioids don't work, or they work, but they're super addictive and not good for us. So you guys do these awesome modalities to treat depression and chronic pain. And, tell us a little bit about how you would assess someone and determine, what they would need. I mean, I can't even tell you how many through my life doctors would say, okay, what are you taking for pain? And I'd be like, nothing. I mean, I could have been one of those people that just every time I went to the doctor, got my, bottle of Oxy. But I just learned being in the healthcare that was probably not a good idea. So I just tried to stay away from it, thankfully. But I have used some of these modalities. So I'm excited for you to share and teach us, for those of us that are watching, what are the options now? How can we be pain-free? How can we treat our depression? How can we sleep better?
Yeah, and when we first, so when patients first come to us, we obviously do an assessment, and we're looking to see what the patient's symptoms are. Typically, I'm also looking at imaging because if they have back pain or pain that's shooting down their leg, I want to look at the MRIs and the X-rays so that I can see exactly where that pathology is, because then that will put me in different directions, as to whether we're going to try an epidural steroid injection first, or if their pain is more from their facet joints, the little joints in the back, which is a different procedure to target those. It's also very important to talk to the patient, right? What have they tried? What's worked? What hasn't worked? What medications have they tried? How effective were they? What was their dose? And then I think, as chronic pain providers, it's kind of, it does an injustice if we don't, to the patients, if we don't go further, right? If we don't ask, how is this chronic pain condition that you have, how is it affecting your life? How is it affecting your sleep? How is it affecting your function? I always tell my patients that, I can get you to a 0 out of 10 pain, but you would be asleep on the couch all day, right? That's not functional. That's not reasonable, right? Our goal is to minimize pain as much as we can, and improve our function. So I'm always asking patients after every treatment, every injection that I do, not only how much was your pain reduced, but how much was your function improved? Were you able to walk around the mall? Were you able to go to your granddaughter's soccer game that you weren't able to do a few weeks ago? And I think by pointing out kind of those small victories to people, they realize that maybe it did help a little bit more than I thought it did. Maybe the pain isn't overall 90% better, but my function is improved. So I always stress functional improvement as well as pain reduction.
Well, and recognize and celebrate those small little victories. Like, it's so easy to not notice. And then like we need to be reminded of, are you better than you were yesterday? Are you better than you were 3 weeks ago? Right. So.
Exactly. And everybody remembers the moment, right? It's hard to gain perspective as to how things were previously. So it really takes a lot of introspection, I think, on the part of the patients, because oftentimes, unfortunately, our results are not 100% improvement. I always set expectations when I first see patients. It's getting 100% improvement. We do our best. We do everything that's within our arsenal, but 100% pain improvement with chronic pain conditions is often, it's not a reasonable goal. But if we can get somebody 50 to 80% pain reduction and functional improvement, that's really significant to most people.
And timing is key, right?
And
Yes.
I would add that within pain, there's 2 major branches that we sort of evaluate for. One is neuropathic and the other is nociceptive. Neuropathic pain is where your nerves are malfunctional, where they are transmitting heightened pain signals compared to what they should be transmitting, or their normal painful stimuli are causing pain, or they're just firing at baseline without you doing anything. And oftentimes nerve pain gets worse at night. And so with a patient who has nerve pain, if I follow up with them and they say their sleep is getting better, I know that their pain is getting better. Mm-hmm. Whereas with nociceptive pain, which is actually the standard kind of pain that you would expect for arthritis, standard conditions, cancerous pain in many cases, the pain is not necessarily worse at night. It might be worse with activity. So I find that in evaluating patients that have neuropathic pain, evaluating their level of sleep is very important. If I'm able to devise a regimen that helps their nerve pain, it'll often concomitantly help their sleep. Another point to that is acute versus chronic. Patients who have pain right after surgery or have a flare of pain may respond to certain medications that make you sedated, like gabapentin, pretty well. But I find that in chronic pain patients who are on the maximum dose of gabapentin for years, it no longer sedates them. They become tolerant to it, and it no longer really helps that much. So when you're evaluating the treatment of a patient's sleep and pain, there's actually a lot of factors. Those are just 2. There's a lot of factors to consider when choosing the medication, as well as the expected outcome, where gabapentin right after surgery will help with sleep, which helps with the perception of pain, and it can also help with nerve pain at night. overall, that's a great treatment temporarily, but chronically, I feel like they're going to get used to it. It won't help very much long term. And in those situations, you need to find a way to maximize functional status, because a busy person during the day is more likely to be able to sleep better at night. Just general. I mean, I know I'm being very generic in that assessment, but people who lead very busy, active, fulfilling lives generally get better sleep. So that's part of our job as chronic pain docs, is to kind of set those expectations that, you know, we can temporize you, but in the end, you need to find a way to improve your life and improve your fulfillment for yourself, because it's not something I can achieve for them, for people.
So tell us a little bit about some of the science and how that the science and the technology and what's evolving can give us hope, right? Because that's one thing, having chronic pain, you just want to have a little bit of glimmer of hope. So can you share with us a little bit about, if someone's out there watching or here with us today, like, you know, how do I find hope in what I'm dealing with?
Well, there's a few different sort of technological advancements on the horizon. Some are just evolutions of existing technology, others are more profound. So there's different fields within medicine. For example, there's anatomic understanding. You wouldn't think that after the centuries that have been spent writing textbooks, that there would be more to discover about the human anatomy. But just in the knee, for example, we are discovering reliable ways to find tiny little branches going into the knee joint every year. And the techniques for targeting those specific branches improves every year, with new articles that come out discussing the anatomy, how to reliably target the anatomy under fluoroscopic versus ultrasound guidance. And so even that simple step of improving the ability to target these tiny branches in the knee can markedly improve our ability to treat patients with ablation, nerve ablations, for example. And so that's one aspect, just improved understanding anatomically. That's something I focus on a lot. And then there's improvements in different facets of pain management, like neuromodulation, regenerative medicine. So within neuromodulation, one exciting technology is peripheral nerve stimulation. For decades, spinal cord stimulation has been around, where they thread a tiny epidural wire into the spinal cord area, into the epidural space. It's the same thing it's kind of similar to what pregnant ladies get when it's threaded into their epidural space, but this is a bigger wire that's threaded directly up the spinal canal in the epidural area under X-ray guidance, and this can tamp down especially nerve pain that's not being helped by anything else. It can be extremely effective. But sometimes people don't tolerate that very well, or it's not targeted enough. And so peripheral nerve stimulation is something that's coming around, where that anatomical understanding of nerves going into the limbs or into the trunk can be used to by targeting those specific nerves with a neuromodulatory technique, where we guide a little wire right next to the nerve that's transmitting the pain more specifically, and that can help. So that's another branch of medicine of nerve pain treatment and pain medicine that's coming around slowly. And then finally, there's regenerative injections. That's a really exciting branch of medicine that's been stymied a little bit by, it's hard to say, it's complicated, the reason that's not made more progress than it has, but it comes down to sort of the question of ethics, when they were first trying to use embryonic cells, which are also not very safe to use in regenerative injections. And also the ability to transmorph a particular type of stem cell into the right cell for that particular part of the body that you're treating. And there have been some unethical clinics that have promised things that can't be delivered, which has required the FDA to come in and set limits and guidelines for use of stem cells. Nonetheless, it's one of the more effective treatments that we can provide in some cases is these PRP or stem cell injections. So I would
Is
say
that,
that.
is that something that you do in just actual joints, or can it be used in the spine as well? Like in the facet joints, is that something you can do there? It's pretty much any kind of joint, you can use that.
Yes.
Oh,
Yeah, you can use it in any kind of joint. There are other proteins and products that are derived from a patient's blood or from bone marrow that can be injected into the spine epidurally, and sometimes even into the disc if the vertebral disc is degenerated or thin, that have been shown to help with pain, help reduce inflammation, and help improve pain symptoms.
what do you see the success rates are with that? Because you kind of, I mean, I've heard sort of, oh yeah, that doesn't work. Oh, it's just, a money maker. I mean, can you help me feel a little bit better about, your success rates using it there?
Yeah, I think that with large joints, it's very successful. And by large joints, I mean shoulders, hips, knees.
Yeah.
I also do it a lot for the sacroiliac joint, which is the large joint where the sacrum meets the pelvis, which a lot of particularly women have SI joint dysfunction, sacroiliac joint dysfunction. So we found it very successful in those areas. We have done several patients where I've done facet joints, cervical ones and lumbar facet joint injections with PRP. Mostly with PRP. I feel like those haven't been as successful. And my theory with that is that those joints are so tiny, they can only take so much of the product, right? They can only take so much PRP, which is a very small amount, maybe 1 to 2 milliliters. And I feel that that's just not enough to get the type of response that we would like. So I feel like it is very good in large joints. I think the smaller joints, it's a little bit hit or miss. PRP and stem cells are also great for ligament injuries, tendinitis, golfer's elbow, tennis elbow. If somebody has like medial or lateral collateral ligament issues. So it's also very good for connective tissues as well as joints.
That's awesome.
And there are studies that you have to balance your interpretation of studies with your own experience. But for example, there's a study that came out in February of 2020 that by Butterman and Thorson, who evaluated the injection of amniotic tissue, which is just basically healthy birth babies. You take their amniotic tissue and you isolate the amniotic fluid contents, and it can provide a lot of growth factors. It's not actually stem cell injection or treatment. It's a growth factor treatment, but they studied that and prospectively in patients who had herniated disc, patients with spinal stenosis, and they found that 80% of patients with herniated disc had marked improvements in pain at 6 months with the epidural injection. An epidural injection is the same thing you get with steroids, but instead of steroids, they use this technique. Steroids usually last a few months. This lasted at least 6 months. They also found about a 50% response in people with spinal stenosis. That having been said, because other clinics have advertised amniotic fluid as stem cell containing, and because they've participated in less than ethical practices in terms of marketing and treatment, the FDA currently doesn't allow the use of that product.
Yeah.
And so it's been frustrating for us. Like that product is very promising for these, many back pain patients, but now we can't use it because just generally the FDA has disallowed the use of what we call allogeneic, which is from other people or other, in this case, live healthy birth babies, products that showed a lot of promise for back pain. So now we're sort of in limbo in a way with regenerative options for back. There's one that's coming up in January that might be FDA approved for intradiscal injection. So there's definitely things on the horizon that have that hopefully will have regulatory approval. But it's actually quite a complex question.
No, it's
Yeah.
okay. It's good. It'll be nice to see what the future holds for, speaking of science and hope, right? Hopefully someday, because it sounds like there's a lot of benefit there. I'm going to ask one last question and then we'll open it up for any questions that our viewers might have. Tell me how you determine whether someone would benefit from ketamine? Can you tell me a little bit about that? I don't actually know much about it, so I'm just curious. Sounds fascinating.
Well, there's two reasons to treat people for ketamine. One is psychiatric or psychological illness. The other is pain. In terms of psychiatric illness, you can have patients with depression, of course, which is the most classically studied indication, anxiety, PTSD. Those are the main ones. There's also people that come to us with OCD, history of addiction. It can help with those things, but not reliably. Whereas I find depression, PTSD, those two especially can be a fair percentage of people, 68 to 70%, tend to respond pretty well. To predict, it's actually interesting. Just generically, the more severe the depression, I find the more likely it is to respond to ketamine, which is actually that's nice in a way. So if they have severe suicidality, I find that's one of the first things that dissipates quickly with ketamine. Sometimes it takes up to 4 or so infusions to notice a benefit, an hour-long infusions, each one being an hour long. Mm-hmm. But sometimes you notice it within hours where their suicidal thoughts.
What are the side effects of that infusion? Like where you're getting it, like what kinds of things? Do you have to pre-treat with Benadryl or anything?
Yeah, so ketamine causes two main things during the infusions. One is dysphoria, where you just don't like the way it feels, because we're inducing a state where you feel like you're dissociated from your body, floating above your body. Sometimes that manifests as numbness of the body, feeling like you're out of control. Other times people find it like they're floating in a pool or riding on a motorcycle without the motorcycle. Sometimes people really like the way it feels, other times people don't. And so we can mitigate that effect with relaxing medications or with a peaceful environment, both of which we offer here. The other major thing that can happen with people during infusions is nausea. And so we pre-treat with nausea, and that's where your Benadryl suggestion comes into play. It can also help a little with anxiety, but mostly actually nausea. And sometimes people are very sensitive to ketamine when it comes to nausea. And so we have a whole armamentarium. We have like a anti-nausea armory here, where we can pull out the drawer and get out our weapons of choice to treat the nausea. So those are the two main things. Occasionally causes bladder irritation. With intermittent use of ketamine, I find that the things that some people are concerned about, like liver or kidney, that's extremely uncommon with intermittent use of ketamine. If people that abuse it daily for long periods of time, they can get, at high doses, they can get chronic bladder problems, they can get liver problems, kidney problems, GI problems. But intermittent use of ketamine with IVs is very safe.
Is it covered by insurance? I'm assuming no.
Our clinic uniquely tries to get coverage for every infusion we do, and we actually have some decent success getting coverage. But I would say most ketamine infusion clinics in the country don't go through insurance, as it can be tricky for some clinics to get coverage. And a lot of the reason that some people open ketamine clinics is to get away from this horrible system of trying to get coverage and get permission to treat people with modalities that we feel are best. So a lot of people just give up on insurance. But we try our best, because we do such a comprehensive array of things that we can't expect people to pay for like a spinal cord stimulator out of pocket. That would be very expensive, for example.
Hopefully those are covered, right?
Yes.
All right, so let's open it up for questions. I'm assuming you guys are doing telemedicine in this great day and age, right? So if someone wanted to reach out to you, acutepaintherapies.com, right?
Yes. And we have a patient inquiry page. We have a provider referral page. So both of those are options for sending us a message. And we're expanding. Actually, we're a little overwhelmed and very understaffed, but we'll definitely, we definitely field all inquiries.
I think we all are. It's the whole world. All right, let's see. Here's a question. What's the difference between ketamine infusion and S-ketamine? Nasal spray. Sorry, I can't say that word.
S-ketamine, yeah.
S-ketamine. Okay, similar. Yeah. What
I'll
is it?
probably take that one. So ketamine is what we call a racemic molecule, which means it has a right-handed version and a left-handed version of the molecule, both existing in equal parts. And S-ketamine, they've removed the left-handed one. S means it's the left-handed version of the molecule they removed. They bottled it and now they charge it like $800 for it for a single treatment. Whereas standard ketamine, you can have a vial that maybe will treat 5 to 10 patients, and the vial costs like 10 or 15 bucks. So you have to keep that in mind when you're thinking about the two, is the cost incentive for using one over the other. So S-ketamine is FDA approved, received FDA approval in I think 2018 or 19 for treatment of depression. And the protocol for S-ketamine is an intranasal spray, is 2 treatments per week times 4 weeks, then 1 treatment per week, and then every other week to every month. Whereas, and it comes in 3 different doses, 1 spray, 2 sprays, or 3 sprays, basically. Whereas ketamine is a little different. We do 6 infusions over 3 weeks usually. That's kind of standard for most places. And then you need a booster infusion on average once a month. So the ketamine infusions require an IV, and you have to sit there for an hour getting the IV and then recover. You have an IV. With the spray, you don't have an IV. The spray, maximum strength, 3 sprays, and that's it. That's the maximum benefit you can derive from that. Whereas ketamine, we can go as high as we need to go to achieve a dissociative effect. Some people are very sensitive at the level at which they respond. Might be only a 5 milligram difference. I have found that IV ketamine is generally more effective and can work even when patients who have tried S-ketamine hasn't worked. That said, some patients respond great to S-ketamine, and it's nice because you don't have to get stabbed in the arm. And so there's some people that respond well to that, but I found that ketamine is a more reliable treatment that can target a larger audience and have a higher generic success rate compared to S-ketamine.
I think it should also be noted that S-ketamine needs to be administered in a clinic where a patient is monitored. So it's not like they're giving it to themselves at home, this intranasal spray. They still have to come into our clinic. They administer the intranasal spray to themselves, and then we basically just monitor their vitals. They have to sit here for, I think, 1 or 2 hours. I forget how long. So both IV or intranasal involve going to a clinic to have it done, basically.
Awesome. All right. Any other questions out there? Let me take a peek here. Here's one. What's the youngest age you can treat at your clinic?
I mean, we don't have a strict cutoff. We're generally an adult chronic pain clinic, just because there are a lot of issues in treating children with chronic pain, especially when it comes to pain medications, in particular opioid medications. So we tend to do adults, but I mean, we do see, you know, we have some patients that are as young as 15 or 16, so not legally an adult, but you know,
Close.
Relatively close.
Adult.
Yeah, I mean, we have done ketamine infusions even for patients a little bit younger than that. So
yeah, so if a psychiatrist refers us a young patient, I've had a couple of 10-year-olds, and they really, you know, they don't know what else to do, we'll help out. That with the caveat that we don't know the long-term ramifications of ketamine in a developing mind like that. I think it's very safe because we use ketamine all the time in anesthesia for young kids, but that caveat needs to be mentioned. We just don't know how it'll affect the developing mind over time.
Awesome. So do we need a referral to come to you, or can we self-refer? Can we be a direct referral if someone's watching? Can they just go to acutepaintherapies.com and refer themselves?
Yeah, they can submit an inquiry. Typically, we do try to get medical records from a primary care doctor or a psychiatrist or a prior chronic pain doctor that was treating them, just so that we can get a better idea of kind of the trajectory of their symptoms and what they've tried. So we do generally get some records, but yeah, we don't necessarily require a referral. Typically, people submit an inquiry and then we check with their insurance to make sure that we're credentialed with their insurance, so that, if they do have a visit with us, that it's covered by their insurance.
I feel like the front office is going to get mad at us if we're too generic about that.
Yeah.
But yeah, sometimes it depends on every case is unique, I would say. And it depends on insurance.
Insurance, yeah.
But yeah, we'll always field the inquiry and then figure out if we need to request a referral or not.
That's awesome. Well, I just want to say in closing that I think what you're doing is amazing. I shared that I've struggled with chronic pain for many, many years, and you don't even realize how bad you are until you get better. And I would love to share with you that today I golfed 18 holes of golf. I'm golfing 18 more tomorrow in a tournament for breast cancer. And I truly thought that I would never, ever be able to play golf with my husband. And it's something that I've dreamed of doing. And this past March, I finally was pain-free enough that I thought I am going to learn how to golf. And I got myself some clubs and I got a coach, and dang it, I can swing the ball. And it's
excellent. Great.
And I just want to say, if you're out there and you're struggling with pain, don't wait. Like call these guys, somebody, there's treatments out there to help you, and don't feel like you're weak or unable. You should not have to go through this alone. And again, your sleep should never be a pain. And if the pain is interrupting your sleep, please reach out. I'm Laurie Ledley with valleysleepcenter.com. Ask a Sleep Coach comes directly to me. If I can help you any further from here, I would be happy to, professionally or personally. So Dr. Julian, Dr. Fisk, thank you so much for being here. And I will send out a link to this recording. And I just wish everyone a beautiful night and a good sleep.
Great. Thank you so much.
All right.
Thanks for having us.
Bye, guys.
Bye-bye.
Bye.